EMDownload.com presents Aortic Ultrasound by myself, DQ Mandavia. This talk is going to concentrate on finding aortic aneurysms. Sit back and learn. An ultrasound that really can't wait till the next day. It's whether we do a CT or an ultrasound, the question of whether that patient has an aneurysm has that focused question has to be answered right then and there, that night, that morning, whenever. There are alternate investigations. Obviously, CT is absolutely fantastic. So a helical CT is great. You don't need contrast if you're just looking at aortic diameter. But if they've got good kidney functions, you don't want to wait around for the creatinine. And if you can wait for creatinine, you can get a contrast CT as well. Angiography really is a historical note only. MRI is excellent, really not that practical for our purposes. But you'll see lots of patients that come in, saw their chiropractor for low back pain, and guess what? They found an aneurysm on that MRI as an outpatient. So anyways, ultrasound has a real role in these patients. The anatomy is relatively straightforward. Remember, it's a tubular organ. It's going to lie just anterior to the vertebral body. And that's a key landmark. When we're examining these patients, you want to look just anterior to the vertebral body. We'll see the vertebral shadow, and then we'll see a tubular organ. That'll be the aorta. Remember, the aorta is going to be to the left side of the body. Okay, so meanwhile, the IVC will be to the right. So there'll be two tubular structures side by side. And then we're going to measure the maximum aortic diameter. We're going to measure right from the diaphragm to the iliac bifurcation. And that iliac bifurcation occurs at about the umbilicus. Okay, so you want to measure that whole aorta. There's many different branches. We really don't need to get into the complexity of this is this branch, that branch, etc. The most important branch is the final branch into the common iliacs. Okay, you want to get all the way down. You want to see the full aorta. And a lot of patients, again, you may not see the full aorta. You may see a segment of the aorta. And again, it's going to usually be an older patient that we're suspicious of an aneurysm. That patient could be very overweight, and it could be a difficult study. Now, with that said, usually as an aneurysm gets larger and larger, it pushes bowel out of the way. It actually gets easier to examine as it gets bigger. We're going to use that same probe, 2.5, 3.5 megahertz. We're going to scan in the midline. Again, from the epigastric area right on down to about the umbilicus, and we're going to scan in a sagittal plane and in a transverse plane. Transverse plane is the plane that you really want to do the measurements in, and that is because if you're cutting a cylinder, as the aorta is, and if you're measuring it, and if you're measuring in longitudinal, you could actually get a artifactually smaller maximum diameter. So if you always cut in transverse, you'll get the maximum. So you want to measure in multiple planes, and you measure the outer diameter. Okay, this is an image of a large aortic aneurysm, and the wall, it goes from here right to here. This is actually about a 9 to 10 centimeter aneurysm. That's the true diameter. Now, this diameter right here, from here to here, is the inner lumen. Okay, that's the sort of true lumen. Okay, don't measure that. Right, that's not the full wide diameter is what you want. For our purposes, anything above 3.5 centimeters is a problem. Okay, I always say never carry a coffin alone. Call for pallbearers. And in this sort of scenario, guess what? Get a formal study. Guess what? Call the vascular surgeon. Call lots of people. Surround that bed. Don't you be the only person doing the heavy lifting. Okay, so if you start seeing, because there's this gray zone between 3 and 5 centimeters, and a lot of people say, oh, but it's not 5 centimeters, therefore they're not going to operate. That's completely wrong. Remember, that's for chronic stable aneurysms that are asymptomatic, not in your emergency department at 2 a.m. with abdominal pain, flank pain, back pain. So there are lots of cases of rupture at 3 centimeters, 3.5 centimeters. So if you're in this gray zone area, just call someone else. Let them make a judgment that it was, really musculoskeletal pain, not that small aneurysm that you found. So I actually also like using ultrasound in this fashion in a rule-in fashion. So if I don't see an aneurysm, I actually, because it's elderly abdominal pain, my practice in elderly abdominal pain, because elderly abdominal pain just scares me, is I actually CT those patients as well, looking for another serious cause of abdominal pain.
Is it contrast or without?
Depending on the scenario. Depending on the scenario. Usually with contrast if they can get IV and oral contrast. But that's looking for other pathology, not the aorta now. So here we are scanning, and we are scanning transverse. You can see the marker there on that probe. It's to the patient's right. We're slowly scanning from the epigastric area right on down to that umbilicus.
It's only exactly midline?
This is exactly midline. Exactly midline. And remember, that aorta is going to be just to the patient's left of midline. You're going to see both the organs together, IVC and the aorta. Okay? And right about the umbilicus, that's going to split into two. And then we can also scan the same patient now longitudinally. Okay? And the marker is now toward the head. And you really need to take your time, and if you have a lot of gas, just put the probe in one spot only with a reasonable amount of pressure and hold it. And just hold it and hold it, and then the gas will move out of the way almost all the time. Okay, so just take your time. You'll usually get a good exam. Yes, question, yeah.
The difference between the outer diameter and the luminal diameter, is that muscle of the
Good question about the inner lumen is blood. The very outer diameter would be the outside wall, and that's thrombus is in the middle. It's thrombus. And there may be some calcific wall within it as well. But we want to measure that whole area. That's the width of that aorta. Okay, so here we are scanning now transverse through the mid-abdomen, upper mid-abdomen. And what we're looking at here is the aorta and the IVC. This shadow right here is the vertebral shadow. Take a look at this very carefully. That's a very important landmark. You see the vertebral shadow, and then above that, this is the aorta, and this is the IVC. Okay, so look for that vertebral shadow, then look for the aorta. If there is a question whether the organ that you are looking at is arterial, you can put Doppler on, you can put color flow, but it's not usually necessary. You can usually see that this is the vertebral body, this is right above it, this is on the left side of the body, this is the aorta. Aorta will be a little bit pulsatile as well. IVC can be a little bit pulsatile because it's right next to the aorta and it's maybe getting that pulsation. IVC in thin patients will also be compressible. Here's a sagittal view of the aorta, and we actually have the SMA that's marked off there, so you can actually see branches relatively easily.
How do you know that's SMA? Is it just from your location on the body?
Right, this is up in the high in the abdomen, so superior in the aorta, and then you're going to have the celiac axis there. You're going to have the SMA that'll come off, and you can see that this vessel is actually going. This is the vessel right here, and it's going down this way, and the SMA will travel in that exact direction. But that is not important for you to say, I didn't identify the SMA or the celiac axis. Though that sort of level of aortic ultrasound is not what we're doing here. We just want to know, do we see the full aorta, and is there an aneurysm?
Is that longitudinal or transverse?
This is a longitudinal image.
Are you kind of high up epigastric?
We're up higher, yes, because we're seeing the celiac axis and SMA there. So this is a transverse view of the abdomen in a normal patient. This is the vertebral shadow right here. Okay, this is the aorta right here. This is IVC over here. And this is going to break into two. Do you guys see it right there? See it broken into two? Right here? That's the two iliacs. Now we're up at the top again. IVC over here. Vertebral shadow right here. This is a thin patient. Actually, as you're scanning through, you can actually see the discs in between. See right there? That's the disc that we're seeing. But this is the aorta. This is what we're concentrating on right here. And even though I did not freeze and I did not take the measurement cursor and actually measure it, I can tell just by glancing at that that is normal, right? Because we have the markers, these red centimeter markers off to the left. So I can tell you that this is about 1.5 centimeters aorta. And we're scanning right from the top all the way down to that bifurcation. Yes, question? The bifurcation is almost always at the right about the umbilicus, yes. Now this is the same patient we're now scanning longitudinally. Okay? So this is the aorta right there. This is a thin patient, young patient. You can see aorta relatively easily. If you have an aneurysm, the aorta could be ectatic. You can only sometimes see parts of it. And that longitudinal, it's not going to be a nice thin straight line. It's not going to be like that. It's going to be curved. So this is all aorta. Here's another one. Here's transverse view of that aorta. Remember, vertebral shadow right here, and this is the aorta right there. This is longitudinal, same patient. Do I stop at the bifurcation or keep going? I usually stop at the bifurcation. Now, can a patient have an iliac artery aneurysm and have just groin pain? Yes. But that's beyond really the scope of what we're doing. If you really suspect something unusual like that, get a CT or a formal scan. Obviously, as you're scanning down, and you could absolutely detect an iliac artery aneurysm. But we're talking really primary abdominal aortic aneurysm.
So you document these for your QA. You take a picture at the beginning. You take a picture at the bifurcation. Those like your documentation.
Well, multiple views all the way along. Yeah, the 3 or 4 views, and a longitudinal. That would be ideal. So here we have aneurysms now. We have saccular aneurysm over here on the right side, and we have fusiform aneurysms. Remember, almost all these aneurysms will be below the renal arteries. Here's a large aneurysm. This is a still image, large aneurysm. This is actually measured there. We have the cursors there, 5.1 centimeters by 6.1 centimeters. So obviously large, something we need to worry about now. Here's another patient with a large aneurysm. And this is not measured, but it's at least 5 centimeters or so. Now this patient actually has components of most likely a dissection as well. Now this is a different diagnosis, different pathology, obviously aortic pathology, but different sort of pathogenesis. But we see a true lumen here. You see some thrombus here, but we see another lumen here. Okay, and I'll show you an example later where how you put color flow, you can actually see 2 lumens. Here's another patient with abdominal pain and back pain, and this is the aorta here that we're looking at. This is 5.7 centimeters. And you can see this is the measurements right here that we're looking at.
You measure from the inside of the wall?
From the outer wall to the outer wall always for measurement. Outer to outer always.
How do you decide the upper?
Well, this is a still shot, and so it may be difficult for you to, but as you're scanning the whole thing, you'll get a feel of this is the wall, the outer part, this is the outer part. Obviously, at most you might be off as 0.5 centimeter. Now, 0.5 centimeter, whether you're at 4 or 4.5, for our purposes, you know it's an aneurysm, you're going to move ahead. If it's that much a judgment call and you're worried about it, get a CT. But not on this one that well, no. You do not see vertebral shadow that well on this one. But we do right here. So here's a large aneurysm. This is about a 9.5 centimeter aneurysm. Okay, this is longitudinal view right now, and then we turn it over, and this is transverse view. Okay, very large, obviously. There's actually a very small amount of fluid right along here. A little bit of retroperitoneal leak that you can see as well, which is obviously a problem. Now, the retroperitoneum usually is not well visualized. If you're worried about retroperitoneal leak and those sort of things, you're going to need a CT. Right. Let me show you that fluid again. Just a little trace of fluid we see right there. Okay? Here's another patient that we're looking after. We're scanning the abdominal aorta, scanning transverse. Now this is longitudinal. Does everyone get an idea where the true lumen is and the outer diameter of that aorta is? So this area is the inner lumen, right? That's where the blood is flowing. But the actual diameter is from here all the way to there. Okay? Yeah, that's thrombus. That's all thrombus.
What would calcium look like?
The very edges that are hyperechoic, that's calcium. Just like we saw with the gallstone. Take a look at this patient, transverse view again. So start off looking normal, but look at this aorta from here to here, pretty wide, here to here, and normal right there. This is IVC, this is vertebral shadow right here. And these are really satisfying cases. Sometimes these are cases that you weren't even suspecting the guy had an aneurysm. You thought there was something else going on, and then you pick this up, and I mean, this is the difference between night and day as far as this guy's prognosis. The fact that you pick this up, and he's going to have an operation, he's going to do okay. So these are really satisfying cases to detect. Take a look at this. There's another large aneurysm. Scanning mid-abdomen. Now this is more longitudinal now. This is the outer aorta right here, all the way to there. Right from there to there. There to about there. So this is about a 6 centimeter or more aneurysm. Right now, that's longitudinal. Right now, that's longitudinal. Now, right now, we're transverse. Now, you're saying to me, why doesn't that look like that other aorta, nice thin straight line? This is an aneurysm. This is an aorta that's going to be twisted and not in a normal straight up and down pattern. That's why you only see segments of it. That's why it does not look like one big giant aneurysm in one plane. Yeah, question in the back.
How much pressure do you apply with the stroke over the aneurysm at the time you do it?
I mean, just enough to get an image. I mean, you will need to put pressure if you don't see anything. You'll put more pressure. You'll get a sense of that in the lab.
And it doesn't bother the patient?
Not usually. It does not bother the patient. No, it's not that much pressure. No. But the times that you need to put more pressure is when you don't see anything at all, and then you have all gas, and then you need to put more and more pressure, and then the aorta will come into view.
And I have one more question about terminology. Way back at the beginning, you were talking about shadow being cast by a hyperechoic, and then you call it shadow also. And when you see the vertebral, you call it shadow, but the vertebral line is really hyperechoic.
Right. The vertebral body, right here, this is hyperechoic. Things that are bright white are hyperechoic. Right. But below that is a small shadow. Absolutely.
So you call that shadow?
That's the shadow. That's the shadow. Hyperechoic areas will cause shadows if they're together. So like a gallstone is hyperechoic and causes a shadow.
So when you say vertebral shadow, you do not talk about the bright.
I'm talking, the shadow is actually the dark area.
The dark area.
Dark area. Shadow is the dark area below. The hyperechoic area is the very top of it. But that's the landmark. I want you to identify that hyperechoic top of the vertebral body. And then you know just above that, that's the aorta. That's your landmark. Here's another patient with aortic pathology. We're scanning transversely. And you guys recognize that there's seems like there's almost a septum in the middle of that aorta. The aorta is dilated, so you know that you're done as far as from our exam. It's a dilated aorta. They're having symptoms. We're going to call people. But just so you recognize that, hey, there does appear to be maybe 2 lumens here. Okay, so you could actually, you get a little fancy, you could put flow on and actually see if there's 2 different lumens. Because obviously, if this is a dissection from the thoracic aorta, you might probably be going to calling a different surgeon, right? You're going to call a thoracic surgeon rather than a vascular surgeon. It's a different pathology. It can be treated non-operatively, etc. So this is a patient with similar pathology. We're scanning longitudinally. And we put the flow on. Do you guys sense that there's flow in 2 different lumens? Okay. Now, is this bedside ultrasound for emergency medicine? No. Do you have the option to hit the little button, hit flow? Yes. So, so you've already got enough information, again, at the bedside to make the phone calls that you need to, get formal studies that you need to, get the consults you need to, etc. But as you start doing this, you will start seeing things like this. Okay, pitfalls. Bowel gas. That can be at the top of the list of any part of abdominal ultrasound. Bowel gas. Lots of gas, you're going to have difficulty seeing anything. If you have something in the retroperitoneal moving that aorta around, whether it be nodes or tumors, that can make it more technically difficult to examine because the aorta is not really where it should be. Same thing with the ectatic aorta. Make sure you get all the way down to the bifurcation. That whole aorta needs to be imaged, not just a couple of centimeters, the whole thing, because otherwise you could miss a focal bulge. And if they've had previous repair of the aorta, either with a stent or with an operative repair, all bets are off. Okay? Get a formal study. That's not our territory at all. Stay away from that aorta. Call other people to help you. Any questions on aorta?
Maybe a blunt question, to be blunt. If you have a hemodynamically stable patient, why not just go to CT?
Good question. Hemodynamically stable patient, should you go right to CT? Absolutely. Is the tech there right now?
So why?
Tech is right there?
Yes.
Radiologist right there?
No, but you can get it read, teleradiology within 30 minutes. Again, hemodynamically
So that's,
stable
okay.
patient.
So if it's hemodynamically stable, well, then it doesn't matter. Then you've got great backup. You've got 30 minutes is not bad. Now, I'll tell you, if you think they have an aneurysm and they're stable right now, that doesn't mean they're stable 15 minutes from now.
Right.
And I'll tell you, 30 minutes head time for that vascular surgeon and the OR team and blah, 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 that is still powerful for that individual patient. So I personally would like to quickly scan them if I'm really, really suspicious of aneurysm. Yeah, I do think it helps you. Because, again, every minute in that sort of a case is percentages off your mortality. Onto your mortality, sorry. Yes, question. Make sure you see the entire aorta. That's the thing about the bifurcation, all the way down to the bifurcation. Yes, another question in the back. Right. This brief lecture is on abdominal aorta. Right. You could have an aneurysm of any artery of the body: cerebral, popliteal, iliac, etc. So obviously we're not going to be that expansive, but so if you could have an aneurysm of your iliac artery, absolutely. And if you are suspicious of that, get either a formal study or a CT. Obviously, it's a matter of following that iliac artery down. But that's again beyond our scope. If you look at our practice guidelines within that ASAP scope of practice, iliac artery aneurysm is really not on that list. It's abdominal aorta.